Thank you, Terry, and thank you, Kelly, for organizing this event as an inaugural event. And I welcome my four colleagues who I think need little introduction, but all of their titles and their current affiliations are on the Facebook invitation. I suspect everyone saw. I really appreciated the questions that Kelly and Terry were able to provide us earlier this week. They were very rich, very complex. I apologize in advance that it will be highly challenging to get to all the questions in less than 60 minutes now that we've started. And I've tried to pick some as priorities because I thought that they were really very relevant issues as to what's going on, both in, let's say, the research medical world about trisomy 13, 18 related disorders, but also in sort of management care issues. So again, I apologize in advance for questions that we're not able to get to. I would like to say that just also in the way of introduction that Dr. Green, Menon, and Showalter are on the Medical and Scientific Advisory Board. For a long time, I've wanted to invite Dr. Hammel to be on the board. He doesn't have to answer now, but you'll get an email invitation to be on the board. But the five of us are only 5 of the 16 people on the board. So there are other disciplines involved. And I told Kelly and Terry it would be a good idea that we could do this at other times in the year and have representation from other board members. So let me just have a few introductory comments and we'll get down to the questions. I think this is actually a really exciting time, in my opinion, as someone who has been thinking about both the scientific aspects and the care aspects of trisomy 13 and 18 for more than 40 years. Only about 10 years ago were we having discussions that intervention made a difference in the outcome of, in particular, children with trisomy 13 and 18. It was only a little more than 10 years ago that published papers were appearing on cardiac surgery, and really only since 2017, when 5 papers emerged, including one that Dr. Hammel was a co-author on, that we were even talking about cardiac surgery. So it's really a different time in the history, as I've seen it, as being a watchful eye for more than the last 4 decades. There are clinics devoted to trisomy care springing up around the country, led by the clinic that Dr. Hammel was a part of in Omaha. There are other clinics springing up as well. There is the work of Dr. Jean-Pierre in Montreal with Barb Farlow, a member of SOFT, that has really gotten the parents' perspective on care and issues. And there is the work that Debbie Bruns, member of the Medical and Scientific Advisory Board, Debbie Bruns has done with TRICE that is actually still ongoing. So it really is exciting. And it's really different. If you did a search on trisomy 18 and 13, 15 years ago, you'd find articles that were about descriptions of what people found on ultrasounds prenatally. So it is a different time. So let me start with first question by Jessie, if I said her name correctly. And I'm going to have all the members of our panel answer this question. What inspired you to be involved with trisomy patients and SOFT? What areas of medicine do you see children with trisomy need advocacy? So what inspired you to be involved with trisomy patients and SOFT? Scott, do you want to start it off?
Sure. Hi, I'm Scott Showalter. Just my professional background, I practiced as a general pediatrician in Denver for years and years, and just the last several years retired. And how I got involved is pretty easy to say. So the background is my wife and I years ago had a child with a son, Patrick, with trisomy 18, and I had been practicing pediatrics for about 10 years out of training at that time, and I had not taken direct care of any kids with trisomy 18 or 13 at that time, which is true for a lot of primary care physicians that often, as far as direct care, there may be one or two in the life of your practice that you see. So I was, it was undiagnosed. Patrick was undiagnosed before delivery, and we found out with the chromosome test about 5 days later. So, so this led to exploring more first about trisomy 18, and actually the social worker at the hospital where Patrick was delivered told us about SOFT, and we attended, my wife and I, Vivian, attended the first national conference in Utah, and that was the beginning of our journey with Patrick and the world of trisomy. And I'll just have to say that first conference that we went to was pretty amazing, to walk into a room with families that were going through the same thing you were. And out of all that, over the years and attending most all of the conferences, we've made many friends. And coincidentally, as John mentioned to a few of us earlier, John and I were in training 10 years before, or a little more than 10 years. And we were friends then, but we had kind of lost contact when we both moved to Colorado and to Utah. And we found out that when we investigated SOFT, that John was the medical director for SOFT. So that has been a great thing, renewing that friendship with John, both personally as friends and on a professional basis. So that's how I got involved, and SOFT has meant so much to Vivian and I through the years, and I will leave it at that.
Thank you, Scott. So, Shaji, can I ask Dr. Menon, can I ask you to address this question as well? Dr. Menon is a pediatric cardiologist at our institution at Primary Children's.
Yeah, so good evening, John, and thank you for inviting me, Kelly, Terry, and the SOFT organization. It's a pleasure and privilege to be here. So I started my medical career about 30 years ago in India, and I was taught very vehemently that trisomy 13 and 18 were lethal conditions, and there was really not much to be done. In fact, any intervention was discouraged. I did my pediatric residency there and a fellowship in pediatric neurology, and then I moved to United States about 20 years ago. And about 15 years ago, I joined University of Utah and had the pleasure and privilege to take care of a trisomy 18 family. And I realized how wrong the education that was given to me was regarding both lethality and quality of life. There was all sorts of myths surrounding trisomy 13 and 18. And unfortunately, in fields where physicians are very focused on aggressive life-sustaining care like cardiology and ICU, they still have these strong held belief of lethality. I had the privilege and honor to work with John, who has been a great mentor, a friend, and a colleague. And, he really taught me a lot of the things that I know about trisomy 18, almost everything. And I realized that families with trisomy 13 and 18 go through a lot of struggle. And that, it really changed my attitude towards trisomy 13 and 18. And I wanted to be an advocate for these families. And obviously being part of SOFT really helped me, at least solidify some of my thought process in terms of how I can approach these patients differently. So.
Thank you. So Dr. Glenn Green, could I have you unmute yourself and address the question of what inspired you to be involved with trisomy patients and SOFT?
So my first experience with trisomy 18 was as a medical student with John Carey as my mentor, identifying a child and here are the things to look at. And so it goes back a lot longer. I don't know if he even remembers this, but it was it was inspiring for me. And he talked about, oh, look at how the fingers are overlapping and look at the feet here. And these are all these things to make a diagnosis. And so there were very interesting things that I picked up as a medical student. I've always been interested in very rare diseases. And I felt that is a calling or inspiration, or it's hard to describe exactly what it was, but something that I felt compelled to do in high school. And so I've always been interested in rare diseases and trying to identify treatments and understanding people with rare diseases. So I've got a practice that has a lot of very complicated kids. And about a decade ago, a family came in with trisomy 18 and said, hey, is there anything that you can do for my daughter? And so we did an evaluation, said, yeah, there's some things that we can do to make a difference here. And it made a huge difference, not only for her and the comfort for her and her life, but for her family. And then started meeting more and more families of kids with trisomy 18 and seeing these kids grow up and become older. It's just been a great pleasure for me, and it compounded my own interest and my thoughts about how can I bring the care that we're able to provide to more children and families.
Thank you, Dr. Green. And hopefully we'll give you an opportunity to talk about your comprehensive airway evaluation need in the newborn period. Dr. Hammel, have you unmute yourself too?
Thanks for the reminder. Still figuring it out 2 years into this. Yes, in fact, my own experience echoes Dr. Green's in a lot of ways. I mean, to me, this is simple. I was attracted into congenital cardiac surgery because I enjoyed being presented with challenging opportunities to try to find a way to make things better. And like everyone in my medical training, I was taught, well, there's nothing you can do for these children. They have trisomy 18. Which I just found to be preposterous. There's always something you can do to make someone's life better somehow. And so perhaps it was a bit because I was naive, but when I was presented with a few children with trisomy 18 and medical and cardiac conditions that I otherwise knew how to treat, I just treated them like any other child and found that, in fact, I felt I had made their life better. Risks are high, but I think there's always something you can do. And so it's sort of an amplified version of why people go into medicine in the first place. I mean, so there's a group of people that you can develop the capability to help. And that for me, it's the same as the reason I went into medicine generally.
Well, thank you. I want to keep I'm going to quote you, treat like any other child. So let's keep that in mind.
Let's keep that quote front of mind, because that is actually something that I want to talk about. Because if I said treat like any other child, that isn't exactly where I want to end up. But maybe in the course of our questions, we can get to that.
Yes, let's do, because I would like to hear what you're going to add too, but maybe when we get to the question that's about changing the narrative, that you might want to uh, expound on what you were referring to.
Thank you. Yes.
I can already see what a rich discussion, but how challenging it will be to answer questions. I think I'm going to take the chair's prerogative, Jesse, and try to answer the next two questions concisely so we can make sure we can address the next series, which are about cardiac care and cardiology. But Jesse also asked, what areas of medicine do you see children with trisomy need advocacy? And I would add in, and I'm just going to simplify the answer, but two groups of specialists that I really think, and this gets back even to the changing narrative issue, would be our obstetrics and gynecology and maternal fetal medicine colleagues. I think that the culture and the narrative that's somewhat embedded in my colleagues or in that, and I've spoken to about that, that's an area of advocacy. And we've talked about this before and perhaps even orienting webinars in that direction. The other group of my specialists who I think really have, I'm going to say, gotten it over the years are our pediatric palliative group. But I think sometimes I hear them have a language that has in between the lines some directiveness to it. So I think our pediatric palliative colleagues and our OB/GYN colleagues, I would put them on my priority list as in being important to hear about some of the messages hopefully we're going to convey. So let me go to the next question, which, let's see, I'm not sure I have this. So yes, I guess this is Meredith, who mentioned her daughter is Rose. And I'll try to paraphrase some of the question. A lot will be about cardiology, and for Dr. Hammel and Menon about surgery. So Rose is 4 years old, and they traveled to Omaha at 6 weeks, and Dr. Hammel repaired her heart. She is thriving, exclamation point. The question, in the rare trisomy community, children with congenital heart disease are given very little hope. In our case, it was consults that brought us to life-saving care in Omaha. Question, would you recommend that rare trisomy children parents begin consults as soon as possible and plan on at least 3 when seeking heart repair? So if I could ask maybe Shaji first and then Dr. Hammel. So would you recommend rare trisomy parents begin consults as soon as possible and plan on at least 3?
Yeah, so I think the process of consultations should begin even before birth. As soon as the diagnosis of trisomy 13 or 18 or any trisomy is made, and you know that the baby has a heart defect, I think some of the important questions that need to be answered is the center you are in equipped to deal with the heart condition and whether they offer a comprehensive care for these kids. If not, I think that is an important time to look for or find centers that are willing and able to take care of these kids with complex medical needs. And once after birth, again, I think once the parents make a decision of going ahead with aggressive or medical care and correction of defects, I think it is important that we do everything. We start the consultation process early because oftentimes these patients need early intervention in form of upper airway obstruction intervention or other interventions to make sure that they are a candidate for surgery when the time comes. And I mean, it is that right now, many centers are unfortunately not equipped or able to provide these care. So it is critical that, you start the consultation process early. As soon as you have the diagnosis and find centers that can actually help you. And most centers will be open to the idea of helping you find a center, even if they cannot provide the care, find another center that can provide the complex care that often some of these children need.
Thank you, Dr. Menon. Dr. Hammel, would you like to add to that or clarify that?
Yeah, I would say that when a family has received a diagnosis of trisomy 18 or 13 and a cardiac defect, I think that really the first priority is for them to be working closely with their geneticist, genetic counseling, maybe in a given setting, it's palliative care, but to learn what they can learn about life with raising a child with trisomy 18. Because the important thing for them to communicate to their cardiac care team and their obstetrical team and their neonatology team is, I understand what trisomy 18 is, and I want to raise my child despite they have trisomy 18, and I want to try to bring about the best medical outcome that I can for that child so that she can have the best, longest life possible. And I think that's really the most important thing to communicate first, because until the team realizes or acknowledges that you accept everything else and you just want their help taking care of the heart, then they're a little bit they lack your guidance as far as what it is that you want to have happen. I don't think multiple consultations really should be necessary. I think that there are very few units that really actually lack the capability of taking care of these patients. Certainly there are units who have, through frequency of exposure, there are units that have a greater capability, but mostly we're talking about cardiac problems that can be treated by the vast majority of units if they understand that that's what they are going to do. If they understand that that's their job, like, I want my child taken care of. He has a heart defect. You're the heart defect doctors. Talk to me about how you're going to fix his heart defect. If you're not getting that and you're getting resistance, then absolutely the earliest possible opportunity to make alternative arrangements would be beneficial. But I would really like to see that happening in more units.
And Dr. Hammel, I know you moved from Omaha to Michigan to Grand Rapids, and from my previous conversations we've had by email, I think you're going to be in a position of accepting patients there in the upcoming months. Is that correct?
I'm working with the hospital to. I really would like to. I'd like to put together a program. I'd like to build an exemplary program for the nation of how an entire hospital network could just envelop a family with care when they receive a potentially devastating diagnosis like this. From the moment of antenatal diagnosis throughout childhood and life beyond. And I'm working on that, and it's not something that I can do by myself. I'm just a heart surgeon, but it's something that I'm working on. But and certainly I'm eager and happy to take care of children with trisomy 18 who are within our ordinary system. But I really and I enjoyed receiving, like Rose, for example, from California. If that doesn't make you feel good to have somebody come cross country to have you save their life, I mean, you're in the wrong field. But I really don't think that's the future. And so yes, I'd like to build, and I feel like I'm in the process of building a trisomy 18 care program that would be the ultimate. But I really think that that the future is for this kind of care to be available in everybody's home cardiac program.
Thank you. And this part of your discussion of the exemplary center reminds me of something Dr. Menon has mentioned to me in other areas of pediatric cardiology, and that is centers of excellence. And we've talked, this is at the board of directors of SOF, not the scientific medical board, but the actual board of directors, about defining what is a center of excellence. Certainly the center you talked about would be one. I think that's something we should still look forward to as an idea. In the meantime, you alluded to this, Dr. Menon alluded to this, families I think are still in this position of what to do when their institution either feels like that they can't do it or actually even floridly declines to do it. I think in that case, the soft registry on trisomy.org that Ann Barnes created and curated does list hospitals that have done surgery before. And you can tell certain centers like Boston Children's, Cincinnati, Stanford, that have done more than 2 or 3 surgeries. In addition, as mentioned in the question, I do know, because I've been hearing this from them, that both Cincinnati Children's, sort of towards the Northeast, but then Boston Children's in the Northeast, and I know Stanford as well, have been accepting patients who feel like their institutions can't do the surgery, or have in some cases actually declined. Shaji and I are in a position of liking to feel like we can make the same thing happen at primary children's, but we still have a ways to go with that. Anyway, in the interest of so many still complex questions, let me there's a question I want to relate to both of you, and also to Dr. Green. I'm going to jump a little bit ahead to Katie's question, which is it possible for a trisomy 18 child, and this would apply to trisomy 13 too, with pulmonary hypertension to have their VSD repaired later in life? Is it possible that pulmonary hypertension may improve later? And Shaji, if you would help address that. So it's a child with pulmonary hypertension have the VSD repaired. Both you and Dr. Hammel, but also Dr. Green could weigh in on that one as well.
So, yeah, it's an excellent question. Pulmonary hypertension and the airway obstruction is almost inherent to trisomy 18 and 13. I have yet to find a patient who does not have some amount of upper airway obstruction and some amount of pulmonary hypertension. So it is critical that we are really aggressive in treating upper airway obstruction to reduce the severity and progression of pulmonary hypertension. The other thing is, which I emphasize, is early intervention to close shunt lesions, because patients with trisomy 13 and 18 can have an accelerated pulmonary hypertension course. So in many cases, still in infancy, if the patient is still in infancy, if you take care of the upper airway obstruction and treat the pulmonary hypertension, there is a possibility that you can reverse some of the pulmonary hypertension and the patient may be a candidate for surgery. But again, it comes back to the issue of early intervention to decrease the severity and progression of pulmonary hypertension. After the first year, sometimes it becomes really hard to reverse a severe pulmonary hypertension that has established. I think patients with trisomy 13 and 18, compared to even trisomy 21, have a more accelerated course of development of pulmonary hypertension. So early recognition and intervention is key. In some cases, you can reverse it, especially in infancy, if you treat the upper airway disease and with medication.
Dr. Hammel, do you have a
it's when we say later in life, I guess I would say I'm very, very concerned and probably pessimistic, because the problem is that when you have a totally unrestricted shunt lesion, a great big VSD, a great big ductus, all of the above, anything that you do with the airway, anything you do with medical treatment for pulmonary vasculature, anything that brings about a reduction in the pulmonary vascular resistance will only be rewarded through an increase in pulmonary flow and shear stress on the pulmonary vasculature that then just compounds the injury. And so I think probably in most cases where there's established increased pulmonary vascular resistance and where the resistance approaches the systemic resistance, I think in most cases, the best way for us to take care of those children is not to try to force them back into the round hole of the VSD closure, but to optimize, as Dr. Menon was saying, optimize their pulmonary resistance and their ventilation and try to get them as far as they can go. But they're probably not going to benefit through VSD closure. On the other hand, I completely agree. I think the evidence is still in the process of being collected, but I think that it's clear that there is a heightened sensitivity to pulmonary vascular injury and pulmonary vascular changes, and that early intervention to protect the pulmonary vasculature is essential if the hope is for establishing the longest possible period of good, comfortable cardiovascular physiology for the child.
Thank you. Dr. Green, I think this is a good time, since both Dr. Hammel and Menon mentioned about the airway. Would you just make a comment about something I've heard you speak about in the last few years? You're known around the nation for it, and that is the recommendation of airway evaluation in infants with trisomy 18 and 13.
So I think there's some very valuable points that have been made just before me. The acceleration of pulmonary hypertension is key. The other thing that will sometimes lead to postponement in kids with trisomy 18 is their small size. And so addressing the role of small size in trisomy 18 that's an important factor that I think is worth considering. Now, going back to pulmonary hypertension, in kids that don't have any cardiac disease at all that have severe obstruction, we can see those kids develop pulmonary hypertension just from airway obstruction. And that is considered an absolute indication for addressing the upper airway. Typically, it's tonsillectomy and adenoidectomy or something like that. Now, kids with trisomy 18 have cardiac disease in addition to airway disease. So both these things can compound on each other to result in worsening pulmonary hypertension. So my recommendation is for airway evaluations in any child that has signs of airway obstruction, particularly considering that they could have cardiac defects that might exacerbate any pulmonary hypertension that's developing. And so what are the signs of airway obstruction in kids with trisomy 18 or 13? Those are things like retractions, snoring or stridor, unusual breathing sounds while a child is sleeping, or hypoxia, decreases in oxygen or turning blue while a child is sleeping. So any of those types of things would warrant an evaluation of the airway by someone experienced in doing so. A sleep study can also provide information separately, and it's common enough for children to have very severe sleep apnea without that being identified beforehand, that it's worthwhile to consider getting a sleep apnea study, a sleep study in any child with the trisomy.
Would that include, Dr. Green, newborns in the newborn intensive care unit who are days or weeks old? You find that maybe there's obstruction. The best you can tell is it's in the collapse of the trachea and the bronchi leading to the lungs. I find my newborn colleagues are often sort of like, they consider themselves doing modified sleep studies sometimes in the newborn unit, but what do you recommend in that context?
So part of the problem is we don't have good normative data, and so that ends up being a little bit confusing, but we're not really concerned about borderline sleep apnea. It's the kids that have severe sleep apnea that we need to identify and treat, not somebody with relatively mild sleep apnea. And so when there's a child that has and a child that's in the unit for a longer period of time, they will have some information. So pulse oximetry is going to be valuable. But if a child's retracting and the pulse ox is just measuring saturations, averaging them over 8 or more seconds, then a lot of times it won't show the severity of the dips that are happening with the obstruction. In formal sleep studies, it will give information that just observing the pulse ox won't. But certainly if the pulse ox is dipping down or a child's retracting or making unusual noises while they're sleeping, that would warrant more thorough investigation as to why that's happening.
Thank you, Jim. Did
John,
you want to?
Yeah, John, with your permission, I'd like to put Dr. Green on the spot just slightly. Share with us your observations based on greater than anybody else's in the world's experience with the issue of central apnea. I haven't really encountered what I would consider to be central apnea in patients that I've been asked to treat. Obstructive apnea occurs, sleep apnea occurs, awake apnea, also obstructive awake apnea occurs. What do you think about the question of central apnea in trisomy 18?
Yeah, that's a great question. And so, so newborns can have a normal level of apnea 10 per hour. And so kids with trisomy 18, like any newborn, can have that. And premature kids have apnea prematurity, and so they can have that. So that's a normal type of thing that doesn't require any intervention. If you look at the literature, it cites central apneas, and so was very confusing to me. But when we've actually looked at the sleep studies where central apneas are differentiated from obstructive apneas, central apneas are distinctly rare. Now, there are some kids that do have central apneas, but this is another point that's worthwhile. If you correct obstructive sleep apnea, a lot of times central sleep apnea will go away. So there's these compounding effects. And so kids with treated obstruction outside of the neonatal period that still have central apnea are distinctly rare, but they do occur.
Thank you.
Thank you, Dr. Green, because as a lot of the people our audience knows, embedded in the literature for many years was this notion that children with trisomy 13 and trisomy 18 frequently had central apnea, and that was the major reason why a lot of children did not make it through the first days or weeks of life. And so I think this discussion that we're having, getting down into the real nuances of it, is highly important.
So, John, one point I want to make is in the first 3 to 4 months, presence of pulmonary hypertension is not usually a contraindication for heart surgery. In fact, if you have a big shunt and you take care of the shunt, the management of pulmonary hypertension and progression is better. So, it's that first 3 to 4 months is very critical. Oftentimes we see pulmonary hypertension in all trisomies, 12, 21, 18, and 13. And if you take care of the shunt, oftentimes it's easier to manage and the progression is slower.
This is important, and I know we only have about 15 more minutes, and I was hoping to answer a few more questions, but so I'm going to have to defer to a conversation we can all have about the idea about the earlier of surgery or better. But I think what I'd like to do, take the chair's prerogative again, and just spend a minute on. And then I'm going to go back to Dr. Hammel, put him on the spot about the point I made, and saying, remember, treat like any other child, and have you go back to what you were going to say, Dr. Hammel. But Brooke had a question that was specifically, what are your thoughts on the quotes, her word, changing narrative about rare trisomies? How far have we come? And how much further do we have to go? I think we could spend an entire minimum of an hour on this topic. And I think that those of us on the medical and scientific board should almost have a strategy meeting about this issue. But I just want to make a few points because I've been thinking about it for a while when I've heard others talk about the narrative. So the other phrase that's used is the paradigm is shifting. And so, and I wrote an editorial recently in the American Journal of Perinatology about this exact theme, paradigm meaning sort of foundation of how we're thinking about things changing. And I think that there is evidence based on hospitalizations, increased surgeries, and more, that indeed the paradigm is shifting. But what about the narrative? So it has been my contention, and I've challenged some of my colleagues in neonatology and also in maternal fetal medicine, that there is a narrative around trisomy 18 and 13 that goes something like this. Probably the best way to go is for nature to take its course and let the child die. And I think that started in the 1980s. And I won't go through the background because we don't have time, but there was this foundation that started. And then I think it's become embedded somewhat along the way that it's almost a culture. So recently I gave a talk at an international palliative care conference, and a very astute PICU doctor, intensive care unit doctor from Seattle said to me in questions, I think there's something about the culture that has to do with treating trisomy 18 and 13 differently than almost any other common newborn condition. So there is something about that culture. And I think that we have to change that culture. And I think the way I would think the way to do it is education for medical students, education for residents in all the related fields. Easier said than done. Just looking at my notes just for a second, I think I'll stop there and make the point. And because of this idea of treating a child by her diagnosis, trisomy 18, trisomy 13, as opposed to the individual problems that that child might have, also seems to be part of this narrative. So Dr. Hammel, I'd like to, I don't even know if what I just said is even related to what you were going to say, but you said you wanted to come back to the question of, quotes, treating a child like any other child.
I do, and thank you very much for the setup and the invitation. I think that there is something changing, and it's been changing in medicine for a long time. If you look back 50 years to the beginning of kidney transplant or even dialysis, we had hospital committees that would decide who was the most valuable person, and then that person would get dialysis. So if you were a banker, you got dialysis, and if you were a sharecropper, you didn't. And fast forward to today, we're still trying to decide whether a life is worth living if you only have a dozen words. But if you can still be a member of a family and live a valuable life in other ways, that's something I think we're coming to grips with as a society. So specifically on this question of, and I heard from many families when they came to Omaha, they said, I just want you to treat my child like any other child. And actually, I hear them, but that's not really what they're asking for. What they're asking for is for us to treat their child with trisomy 18 like a child, just like a child. Acknowledge their humanity and make it our mission, just like we do for any other patient, to make their life better in any way that we figure out that we can. In fact, we can't just treat them like any other child, because they're not like any other child. They're extremely special. They're very complicated. They have cardiac disease that is particular to them, and their body's way of responding to their cardiac disease is particular to them as a child with trisomy 18. So we don't really want to treat them like any other child, but we just want to treat them like a child as opposed to just a diagnosis and or a lump of protoplasm. So I think that the next step, Trisomy 2.0, is for us to figure out the best way to take care of kids with trisomy 18 and treat them like that. And when you were addressing the question earlier in the talk about what specialties, where do we have the most room to, like what's important for us? What I was thinking to myself was the therapies, occupational and speech therapy and physical therapy, because right now, half of children will not feed themselves or participate in their feeding or be able to move around the room or things like that. But we don't really have any idea what kids can do. We don't know what the potential of therapy is because we have never really gotten that far. We've only been worried about survival. So I think that to me, the first thing is to just take them as a patient, take them as a human, a family with a child, and figure out what we can do to make their life better, because there's always something. And then beyond that, if we can, by pooling our experiences, by even generating some experiences, the more that we operate on children, the more that we bring about prolonged survival, the more we'll learn about what worked well and what doesn't, and start to figure out what's the right way to take care of a child with trisomy 18, because we don't know right now. And getting a treatment program to take care of them like anyone else is probably better than nothing. But I like to try to move beyond that, because it's usually different. Okay.
Thank you. That was beyond eloquence. Thank you for that. I think in our interest of time, and I would love to, there's some more questions even related to this, but I think just because of the relevance of the timing, there was a question about the pandemic and COVID that I would like to state, and we can address. Hopefully, we still might have time to open it up for one or two questions. But let me address this question, or pose this question by Jenny, and it's for our children with trisomy 18 and 13 at this point in the pandemic. What type of precautions should we be taking? Having others mask around them, indoor versus outdoor, etc. What type of precautions do you recommend for members of their household when out in public? And then also part of that, do you recommend that children with trisomy 18 and 13 who are eligible receive the COVID-19 vaccine? So the first part of that question is, what precautions do we take in indoor outdoor activities, masking? What do we recommend for the household? Scott, will you would you tackle that? Yeah, and I think you're still on mute there. The sentence of the times are still on
Right.
mute.
Yeah, I think as far as the precautions and masking those issues, I think one thing that John and I have talked about, what's recommended generally is different if you're in a high risk category. And the CDC's list of high risk categories for coronavirus infection, COVID infection, it's changing based on more and more studies, et cetera. But from the way I read it, and I think I would agree, and I think John might agree, our trisomy 18 and 13 kids are at high risk. There's still a question about immune status and immunity in trisomy 18 and 13 kids. But overall, and even the CDC is putting high risk kids in the category of, significant cognitive delays, congenital malformations, etc. Those kids are considered high risk. So, for now, until things change, hopefully things will get better as we go along with the pandemic. But I would still recommend, limiting public gatherings for our kids, and masking in general when out in public. And I think another thing that's important is what's called cocooning. We do this with our young kids, babies who can't be vaccinated for influenza yet. We strongly recommend caregivers and parents get their flu vaccine. I think the same principle should apply for our trisomy 18 and 13 kids. So in the interest of time, I won't go into a little more what I was going to get into, comparing the risk of vaccination with concerning the vaccination question, the risk of vaccination versus the risk of disease. But basically, and one of the biggest concerns is with vaccinations is in children is the concern about myocarditis and pericarditis. And so that's one thing that's being studied, and the risk of that. But again, you're balancing the risk of getting the disease itself. And even though it's rare for children, the multi-system inflammatory syndrome that can occur, and most kids recover from that, but often need to be hospitalized. So I won't go into weighing all the risk of disease versus vaccination, but I would say overall that I would recommend for our trisomy kids that they get the COVID vaccine if they're in the age group where they can. And I think soon, under 6 months to 5, vaccine will be approved for that age group too. So I think that's coming. But
So Scott, why don't, given what you said, why don't work with me, and we'll actually make a sort of statement from the Medical and Scientific Advisory Board, send it around to everyone, and post it on trisomy.org. So you and I can work with that. Glenn, did you have a comment?
Yeah, I've had a number of children with trisomy 18 get COVID at this point, and the kids. So one important thing to state is that it's not just coronavirus going around right now, it's influenza as well as RSV, and it's the worst seasons that we've had for any of these three. And when a kid gets 2 of the viruses, it is absolutely crushing for kids with trisomy 18. a lot of kids will do well with just coronavirus, but there's enough serious viruses going around that it's problematic. So I strongly recommend that precautions still be employed. Although if your child does get coronavirus, you do not need to be worried about imminent death.
Right, but both of the children that I know and Dr. Menon knows, one of them here in Utah, both actually, one's 5.5 and one's less than a year, actually did nicely. But Shaji, could you comment about the risk related to the myocarditis?
Yeah.
Children with trisomy 13 and 18, who of course most of the time have a heart defect.
So I'm on part of the national trial or committee that looks at vaccine-associated myopericarditis. And what we found was myopericarditis is typically restricted to adolescent young males. And it's very, very extremely rare or uncommon in kids less than 5 years of age. Pretty much all of them recover completely with minimal sequelae. And none of the myopericarditis kids in the registry had any genetic disorder. So it's more of an issue in adolescent males. And emerging data from Israel suggests that if you space out the vaccination, especially the booster, the incidence of myopericarditis is low. So I think even though myopericarditis is seen in adolescent males, it's usually patients recover almost completely, and the risk versus benefit is way in favor of vaccination.
Thank you. I think we're actually past the hour, but I wanted to make a comment about this that I've talked about with other members of the board, and that is for the families who are listening and who are considering attending the hybrid soft conference that we'll have in Roanoke in July. I would recommend that you do go to your own primary care doctor, maybe also to cardiologist, if that's appropriate, and get their opinion as well. So I think it's an important decision, challenging decision, but that would be our recommendation. I think this has been a fantastic discussion. We didn't get to about 5 important questions. I really appreciate everyone who asked the questions, and I think it just begs the question, Terry and Kelly, that we probably need to do something like this with various board members, more than just in the month of March, or maybe next year we have, no, I know you guys will fall off your chair, one a week with different board members anyway. But I think we're going to have to close, and was hoping we could work in questions from the audience, but we're past. Yes, Scott.
Just quickly, I'd like to put a plug in for the online book on our website, The Care of the Infant and Child with Trisomy 18 or Trisomy 13. It's a great resource. It's free. You go on the trisomy.org website and you see the complete book, complete text, and includes like graphs for weight and height for trisomy 18 kids, and a lot of other information, and probably can answer a number of the questions that parents have. So I've just
thank you, Scott. There were 2 questions about weight and growth curves. You answered it by addressing that in the book there are the growth curves. In addition, they're also available as growth curves on the professional part, the professional drop down. So there are 2 places you can access growth curves. So for the 2 parents that asked about growth in trisomy, both were trisomy 18, that's the first place to go.
And also reminding your physicians or caregivers that on the website there are numerous articles on trisomy 18 and 13 for professionals and advice. So in educating us physicians, parents should never hesitate to suggest that to their doctor.
Thank you. But I think Kelly and Terry, we're probably going to have to close. We even went almost 10 minutes past the hour. It just shows that this was an important and necessary forum for us to do, and that we just need to do it more often.
Absolutely. This absolutely has, we have a need for this out there. And, you know, I just want to say thank you, first of all, to Dr. Carey, for you and working with Kelly in getting this whole thing coordinated, because that is huge. And to all of you, gentlemen, I don't know that you realize this, and I'm going to Kelly and I were talking about the fact that in some of the comments on the announcing this and on Facebook, we noticed that a lot of the moms are fangirling. So one thing you just need to know is that you are our rock stars, because we do not hear these tunes in our own local town most of the time. So you guys doing this and bringing it out to our families, I think will not only, it's so heartwarming. I mean, as a daughter of a 22-year-old, I wish we'd had you 22 years ago. I'm just grateful we have you now. But in any event, I just feel like the more we do this, obviously, the more we're going to get. But it also gives our families the courage and the confidence to speak and advocate better for their kids. So this has been huge. We barely touched the tip of the iceberg, I know. So thank you. Kelly, anything we need to add at all before we close out for the night?
No, I would just add again my thank yous, and looking at the comments on Facebook, there's a whole lot more fangirling going on. So I agree with Dr. Carey that this is something that we will have to do more often. And it's definitely great information, and we really appreciate all of you so much for sharing this with us. Absolutely.
And to our SOF family, thank you for taking your time to join us tonight. This is on the page. It can be shared. And we will get it up on our YouTube channel as well, so you can share it even easier with those in your life to whom you feel need it. Thank you all very much, and good night. Again, thanks to our speakers.
Thank you.
Appreciate you so much.
Thank you.
Thank you.